We are live. Remember, you're in the shutdown.
Hey guys, welcome back to Medicine Deconstructed. As a matter of fact, this is our first live episode of Medicine Deconstructed. I'm your host, Dr. Jay Rutland. Listen, some of these things that we do is we talk about medicine all of the time. We want to be able to learn how to apply the information that gets thrown our way. Right now, what was just thrown our way is we learned about Trump's COVID-19 cocktail. We learned the medicine that he's taking. Now, as we go live, I'm going to learn about the medicines that he's taking. And it's my job, since I'm deconstructing medicine, to let you know why he's taking these medicines and what these medicines do in your body. So remember, Trump just released last night that he developed COVID-19 secondary to the SARS-CoV-2 infection. He and his wife, along with his first aide, we know for sure have SARS-CoV-2. Remember, one of my pet peeves is people throw around COVID, COVID, COVID. COVID-19 is actually the disease caused by SARS-CoV-2. Some people just have SARS-CoV-2. Some people have the disease caused by SARS-CoV-2, COVID-19. Now let's get into the pathophysiology really quickly. Remember, coronavirus is a virus that is present in the world. All right. There are 7 types of coronaviruses that can infect human beings. 4 of them we pass around every single winter. OC43, HKU1, NL63. These are just examples of normal coronaviruses that cause respiratory illness. Right now, what we're talking about is SARS-CoV-2, the novel coronavirus that started in China in around November, December of last year. The pandemic has now affected over 6 million Americans, I believe, at this time. And we are having our maybe 3rd wave and our increase in peak of infection right now. I want you guys to understand why Trump is taking certain medicines. So what I'm going to do is I'm going to have my crew, since we're filming today, toss out the medicines that he's taking. But first, remember, SARS-CoV-2 binds to the airway epithelial cell in your lung, or your type 2 pneumocyte. Once it binds to the type 2 pneumocyte using the spike protein is going to need to be cleaved, and it uses our protease, our enzyme, to cleave itself so that the virus can enter our cell and use our machinery to replicate itself and reproduce itself. Once it does that, the cell eventually dies off, and when the cell dies off and bursts, you've got a whole bunch of virions, a whole bunch of SARS-CoV-2 viri, so to speak, that are moving on to go infect other cells. Once that happens, your immune system gets activated. Macrophages understand the virus's presence and start secreting different cytokines and chemokines. We know for a fact that the cytokines that are produced are interleukin 6, okay? A little bit of TNF alpha. We're also talking about IP10, all right? MCP3. All of these cytokines are cellular communication molecules that recruit more white blood cells into the area of the lung. If the lung is no longer full of air, that means it's full of this fluid and this inflammation. When that happens, you get really short of breath. Okay, so now let's go through this cocktail. What's the first medicine that we know for a fact that he's taking? So the first medicine that we know for a fact that everybody's probably confused on is called Regen something something number. What this is it's a product created by the pharmaceutical company Regeneron, which is located in a tiny town in New Jersey on the East Coast here. What you want to understand is it's a monoclonal antibody. In fact, this product that Regeneron has created is a combination of 2 monoclonal antibodies. Now, we've talked about monoclonal antibodies before. Monoclonal antibodies are quite simply antibodies that bind to certain things. Remember, an antibody is shaped like a Y. There's an FC portion like my feet, and there's a specific portion that's the Y end, my hands here. What a monoclonal antibody specifically does is it will bind to a specific protein and it will inhibit anything else from binding to that protein. So this Regeneron monoclonal antibody, which is a combination of 2 monoclonal antibodies, they both inhibit spike protein. So they do not allow the virus, coronavirus, to bind to the cells. So, what it's going to do, it's a neutralizing type of medicine. So, when you have a neutralizing type of medicine, a medicine that can inhibit the production or can inhibit the binding of SARS-CoV-2 to the cells, then the cells can't get infected. So, what you're hoping for is for no more of his cells to be infected by SARS-CoV-2. The cells that are already infected, they're infected. But you want to inhibit further infection by using this monoclonal antibody to sort of block the binding of SARS-CoV-2 to the cells. Now, what we know in the studies is that this medicine has reduced the amount of days that you're ill, I believe, and it's also maybe reduced fever and things of that sort. But what it's doing is neutralizing the virus, not allowing the virus to bind to our type 2 pneumocytes or to the small intestine or to whatever cell has the angiotensin converting enzyme receptor type 2. Remember, ACE2R is what the spike protein binds to. And these monoclonal antibodies specifically bind to the receptor binding domain of that spike protein.
All right, I have a question from Health Call Live. Hi, Jamie. How soon will we know whether the press will have a smooth ride or face a serious threat?
That's a good question. How soon are we going to know when the president has a more severe infection or this infection stays mild? That's tough. But what I can tell you is that the median time to hospital presentation, so when I would take the virus extremely seriously, is about 7 days. So 7 days into the illness or 7 days into you knowing that you have SARS-CoV-2 is when you present to the hospital. Here's the problem though. The median time to the ICU admission is day 8. So you can present to the hospital and be in the ICU within 24 hours. And that's when you know the infection is severe. But for right now, we know that he's still not in the hospital. At least that's what we're being told. And so we still assume that the infection is mild. But we do know that he has symptoms.
Okay, Trisha Lawson asked, it used to be day 5 and ICU day 6.
Yeah, the literature that I've read recently is median day to hospital presentation is day 7 and ICU presentation at day 8. I think we're just arguing semantics here. I think what we do understand is that it takes several days for this infection to get going. So you have some time if you take something probably like a monoclonal antibody to inhibit further infection, which is probably why he got monoclonal antibodies. When you look at other therapies that we give convalescent plasma, which is essentially taking plasma out of people who have been through the virus, who have been cured from coronavirus, and we hope to get the antibodies that bound to SARS-CoV-2, neutralizing that spike protein out of that plasma and giving it to other people. So the concept is the same about virus neutralization.
All right, InfoWorld 101 says, what does this say in regards to the statements about COVID Trump has made in the past?
That's a great question. I think from a political perspective, it depends on which statement you analyze. Again, we know that President Trump likes to speak. We know that he likes to talk. And when you do that, you continue to say things that may or may not be true and may or may not be taken seriously. Now, at times, he seems like he's not taking this pandemic seriously. But I think at this point in time, this is something that's going to allow him to transition his thought maybe a little bit, and he'll start to take this more seriously. I think what this means is that, listen, he hadn't personally experienced the virus yet. I'm a physician. More than that, I'm an ICU physician. I see the severity of the infection on a daily basis. And so it's easy for me to tell you that this is a severe infection and that this causes problems. But from his perspective, he hadn't seen it. He didn't really know anyone that had had it yet. But now with this personal experience, I am quite certain he'll take it more seriously.
All right, so I want to go over some more things that you talked about months ago as being treatments for this. Let's talk about what else he's taking. Zinc, vitamin D, Famotidine, Melatonin, and aspirin, daily aspirin.
So,
write your book.
As I've discussed previously, let's start with aspirin. We know that in the intensive care unit, SARS-CoV-2 can lead to upwards of 20 to 40% of the people who present to the ICU may develop blood clots. What we've discovered in the pathophysiology of SARS-CoV-2 and the disease COVID-19 is that your platelets begin to get activated and your coagulation system begins to become activated. Remember, your coagulation system is your blood system, your blood proteins in your body produced by the liver, by the way, that allow your bleeding to stop. If those are overactive, you're going to develop clots. And so we know that these patients do develop clots. So taking an aspirin inhibits platelet activity. Aspirin inhibits platelets from being able to do their job. So I believe that taking an aspirin may in fact inhibit the body's ability to form a clot or to form a plug. And again, in my patients that have SARS-CoV-2, I have recommended them taking an aspirin.
Okay, question. Have you had any experience with leronlimab by Cytidine?
Yeah, Cytidine and leronlimab. So leronlimab, if I remember correctly, is a CCR5 antagonist. Can you just check that for me, please? I believe leronlimab is a CCR5 antagonist. Now, CCR5 is a chemokine. Now, the difference between cytokines and chemokines is pretty simple, but I want you to think about this. When you have a blood vessel, okay, and you have molecules that want to get to a certain place, molecules don't fly. They have to get there in a way. They have to roll. They roll on the wall of the blood vessel, okay? So when white blood cells want to go to a place to fight an infection, they roll on the wall of the blood vessel. And by rolling on that wall of the blood vessel, they can get to the site that they're being recruited to. So CCR5 is a chemokine. In other words, it's a receptor that may be present on that wall of the blood vessel or the lymph tissue that allows the white blood cell to get to a certain spot. So leronlimab, which I believe was used a lot at UCLA at the height of this virus, is a specific monoclonal antibody that inhibits this chemokine. So that way white blood cells can't get to the site infection, can't get to the site of infection. So why would you want that? Because remember, our symptoms are based off of inflammation. They're based off of white blood cells traveling to sites of infection.
Oh, we have hot news. It looks like Trump is being transferred to Walter Reed Hospital. Someone just asked a question here. What are his risk factors? Is he a high-risk group? So, and the fact that he's just being transferred to the hospital is not a good sign.
If Donald Trump is being transferred to the hospital, you're right, it isn't a good sign. It means that he needs support. In other words, his organs are being affected by the presence of the virus. Perhaps his lung is full of inflammation, right? Maybe his blood vessels are full of inflammation. Maybe his heart is full of inflammation. When you have inflammation in those areas, it can obstruct the body's ability to do its job. The lung can't do its job. The blood vessels can't do their job. And so when that happens, you need things like oxygen. If he needs oxygen, then my guess is that they would put him on dexamethasone or Decadron, which is a steroid that will calm down inflammation. And when you look at the literature of dexamethasone and Decadron, what we notice is in people who required oxygen therapy, it reduced their mortality. And so that's probably why he's being transferred to the hospital at this time.
Right. Okay. And sorry, I kind of cut you off a little bit before, but you were talking some about that you also, I mentioned this many times, zinc, vitamin D, and then Famotidine and melatonin.
So one of the things that I noticed in the intensive care unit, and all of my partners have noticed this as well, is that when you look at the patients who have severe COVID-19, the ones that are intubated on mechanical ventilation, they can't breathe on their own, the ones that are in shock, the ones that develop significant hypotension as a result of the presence of the virus, meaning your blood pressure is really low. We check vitamin D levels. They're severely low. There have been a couple of papers that have been published over the last few months that have shown that the lower the vitamin D level, the more severe COVID-19. And so what vitamin D actually does is it allows the immune system to be more efficient. So when you're looking at the immune system, understanding white blood cells want to get in there, do their job, and move on. If your vitamin D level is low, your white blood cells get in there and they stay in there, causing inflammation, recruiting more white blood cells to the area, causing pathology. So I take 10,000 units of vitamin D a day. I take 10,000 units of vitamin D a day because I'm surrounded by coronavirus on a daily basis in the intensive care unit and in the hospital. So I want you guys to know that having an adequate level of vitamin D can mean that your COVID-19 severity is not going to be that bad. It may not be as bad. So that's why I take it every day. To patients that don't have COVID-19 or SARS-CoV-2 and aren't exposed to it every day, I tell them to just take about 5,000 units a day, which is 125 micrograms daily of vitamin D.
All right, so here's an interesting one from my adventures. Do you think he was really taking the hydroxychloroquine, and do you think that prophylaxis didn't work?
Say it with the
Prophylaxis.
Oh, okay.
Right.
So there was a paper published last week, and I think it was published in Lancet. So we looked at hydroxychloroquine. There was a study done in which healthcare providers were offered Plaquenil or hydroxychloroquine as a prophylaxis for SARS-CoV-2 infection. Again, remember, the virus has to bind to our cells to cause an infection. So what we thought hydroxychloroquine did, and I thought this in February, I changed my mind after studies, but what we thought it did was didn't allow the virus to enter the cell. So it almost neutralized the infection. So what did we do? We gave it to people who were exposed to SARS-CoV-2 all the time, and we compared them to people who were not on Plaquenil, and there was no difference. The study showed, and it was stopped early, that it didn't have any effect on the development of SARS-CoV-2. So do I think Trump was taking Plaquenil? It's possible, but I also understand that in the literature, Plaquenil doesn't work in randomized controlled trials.
And yes, hi, Health Call Live. Hopefully you can hear me better. I'll be a little louder for you guys. Let's see. Do you know any of the names of medications that he was on previously?
I don't. Unfortunately, I don't. I only know the names of the medications that he's now receiving.
Right, okay. And so let's keep going with some of the other drugs. Did we go through, we went through vitamin D.
Vitamin D, aspirin, and we talked about the monoclonal antibody.
Melatonin, let's talk about melatonin.
So melatonin, you use that a lot in sleep. So what is melatonin? So melatonin is another type of cytokine. Now, what melatonin does in your brain is it helps you go to sleep, but it also reduces inflammation. It specifically inhibits TNF alpha, tumor necrosis factor alpha, and interleukin 6. These are cytokines that are involved in the cellular recruitment of white blood cells to an area where an infection is present. So melatonin can calm down that inflammatory process. And so I think, generally speaking, when you're going to see that reduction in TNF alpha and in interleukin 6, you're going to see it when you're taking upwards of 10 grams or milligrams of melatonin daily. So it's something in that range, I'm sure I'm sure that's what he's on.
Okay. All right. So someone says, hey, Dr. Rutland, put aside politics, what chances do you think Trump has at surviving COVID-19?
That's a good question. I think that, again, when he was at home, his chances were upwards of 90%. Now he's going to the hospital, right? He's been giving a bunch of different medicines. So his chances are a little bit less than that, but I still say his chances are in the low 90% area because that's what we see. But him going to the hospital informs me that his infection is severe enough for him to need some support from an organ standpoint. So putting politics aside, I would still say his chances are pretty good, but it does make me a little bit nervous because he's going to the hospital. Who knows how sick he is?
Right, exactly. I'm wondering that too because he hasn't tweeted anything. So
He hasn't.
Yeah, it's not good. All right. So anyway, let's see what else we got. Is melatonin good to take prophylactically if working in healthcare? And that's a question from Trisha Lawson.
What a great question, Trisha. So melatonin prophylactically is probably not going to have any effect on you contracting the virus because it doesn't inhibit anything there. It doesn't inhibit spike. It doesn't inhibit nucleocapsid. It doesn't inhibit membranous or envelope protein or any of the non-structural proteins that are present within the virus. What melatonin does is inhibit the cytokines that are upregulated once the disease ensues. And so what I would say is it good to take prophylactically? No, because it's not really a prophylactic type of medicine for SARS-CoV-2. It's more of a medicine that will help you go to sleep, But if you've been around somebody that has SARS-CoV-2, or you share a bed with somebody that has SARS-CoV-2, maybe it'll inhibit some of your symptoms and the development of your symptoms from that perspective.
Cool. Okay, so melancholy acres, is there something to the bradykinin theory?
Bradykinin?
Oh, bradykinin. Yeah, I'm sorry, it's really small.
Yeah, so bradykinin is another type of molecule that can cause inflammation. And so what bradykinin is truly involved in is it ends up causing swelling. So what we'll see in the hospital is we'll see people that have swollen lips and swollen tongues, and their bradykinin activity is up. It's almost like a histamine. And so there is something to that theory, and it could be contributing to illness, but I don't think it's just bradykinin.
Okay, and then I'm going to go back to a question from Christy Wins. She asked, and I think this is relation when you were talking about aspirin. She said, so NOACs won't make a difference in clotting?
NOACs. So I think you're talking about NOACs, which are PO medicines that you can take that are going to thin your blood. So those medicines will make a difference in you clotting. They thin your blood. Now, are you going to take those prophylactically? Probably not, right? You don't really take the NOACs, which are direct thrombin inhibitors. You don't really take them until you have developed a blood clot. Because again, when you take a medicine that can thin your blood and you don't have a clot, you might cause a bleeding episode, which might be rather difficult to deal with.
Okay. All right. And we have another question here from Trisha Lawson, taking us back on track of another thing that you've mentioned many times for treatment. Is he on zinc, and what are the benefits of zinc?
Yeah. So he is on zinc, and that was I think that's the last member of the cocktail that we haven't actually talked about. So zinc is a nutrient, right? So it's like a vitamin. And so what zinc actually does for coronavirus is it actually inhibits one of the RNA polymerases. So for the virus to be able to exist and for the virus to be able to support itself and produce more virions or viri or however you want to say it, the virus has to have a functioning RNA polymerase. Now, zinc, at least in a petri dish, inhibits that RNA polymerase. So I do take zinc prophylactically as well. I take 100 milligrams of zinc a day just to make certain that my levels are optimal.
Great. All right. Well, it seems like that's everyone's question so far. We've gone over his full thing. Is there anything else? I mean, this news of him going to the hospital is pretty. What treatment do you think they're going to be doing? Like, of course, you mentioned medically what they're doing, but
right.
what could they be doing to him? I know that they've mentioned, what about this new thing where they have people laying on their bellies and stuff?
So here's the thing. Once you go to the hospital, here's what's going to happen to President Trump. He's going to get admitted to the hospital. He's immediately going to go to a bed. He's going to get his blood drawn. Now, what are we going to look for in his labs? We're going to get a complete blood count. We're going to look at his hemoglobin, which is the ability for your bloodstream to carry oxygen. We're going to get a look at his white blood cell count. Specifically, we're going to look at the lymphocytes. Lymphocytes are cells like your B cells and your T cells, okay? That lymphocyte number is important here. If that lymphocyte number is around 200 or 300, which is really, really low, it tells me that all of his lymphocytes are elsewhere. So where could they be? In your lung, in your heart, fighting this infection. It's actually a poor prognostic type of sign when your lymphocyte count is low like that. So they're going to look for that. They're going to get an ESR, erythrocyte sedimentation rate, which tells you how inflamed someone is. They're also going to get a vitamin D level to see how low his vitamin D level is. They're also going to get a D-dimer. A D-dimer is a marker of inflammation as well. It'll be able to tell us how bad his inflammation is, okay? All of these markers are important because we get to prognosticate where he is on that spectrum. They're going to get a chest x-ray. They're going to get a chest CAT scan. No doubt in my mind they're going to get a chest CAT scan. They're going to get a CT, and they're going to get a sense of what a CAT scan of SARS-CoV-2 looks like. How much ground glass opacity or inflammation does he have? How much inflammation is throughout that lung? Because that's going to be the issue here. Is he going to be able to withstand that amount of inflammation? It's going to be a problem. So those are the things that they're going to do. They're going to give him Decadron, dexamethasone, no doubt about that. He's going to get steroids to calm down inflammation. We talked about those results earlier. He's also going to get probably remdesivir, which inhibits the reproductive abilities of the virus, right? He's going to get remdesivir. He's going to get Decadron. He's already gotten 2 specialized type of therapies with those combination of monoclonal antibodies. He'll probably get convalescent plasma, which again is taking people's blood who have been through coronavirus and done fine and hoping that they have some kind of antibodies within that plasma to institute in someone to help neutralize infection. But that's what I imagine happening. What I hope doesn't happen is that he gets intubated. He ends up on machines. That's the issue there. Listen, I don't care what your political affiliation is. And again, as a physician, when I look at somebody that walks into my hospital, I want to make sure that they walk out of my hospital. That's my job and that's my duty. And I hope that all the physicians that look at him, that are taking care of him, have those same aspirations. And I'm sure that they do. There's no doubt in my mind that they do.
Right. And then I was wondering, and that would be the plasmapheresis, would be bringing in the plasma from the other patient?
No, so plasmapheresis is actually where, and that's a good statement. Was there a question?
Yeah, someone asked if maybe that's why he's going to the hospital to receive that treatment.
He might be going to the hospital to receive convalescent plasma. Now, plasmapheresis is something different. Plasmapheresis is where you take the plasma out of somebody's body and you're taking out all of the harmful types of things like antibodies that could be causing significant inflammation. We do plasmapheresis a lot in patients that have autoimmune disease, interstitial lung disease, autoimmune lung disease, kidney disease, autoimmune kidney disease, and things of that sort.
I have a question. All these treatments that you're talking about, that seems pretty, I mean, this is a lot that's going on for him. And obviously he's the president.
Mm-hmm.
Are these treatments that are available to your average patient that, like let's say, someone down the street got COVID and was in the same spot that, another 74-year-old man, is this the kind of typical treatment that someone's going to receive at the hospital?
That's a great question. So the Regeneron treatment, the monoclonal antibody, obviously is not available to everybody, right? It's just not. So there's clinical trials going on. And if you're in the clinical trial, you're going to get that therapy, right? If you qualify for the clinical trial, you'll get that therapy. But if I got COVID today, would I be offered those monoclonal antibodies down the street? No, I wouldn't, right? I'd have to qualify for the clinical trial. And I'd also have to hope that the hospital that I went to had clinical trials. You got to understand that a lot of the hospitals, community hospitals especially, don't participate in clinical trials. So you don't have that ability to be able to receive those types of therapies.
Oh, that's good to know. So I guess if you get sick, maybe there should be a list of hospitals you should go to.
Yeah. Generally speaking, in my area, if I have a patient that gets sick, there are hospitals that I tell them to go to.
Good. Okay. Good to know. Okay. Yeah, I think that's pretty much everything that people have asked. Yeah, let's wrap it up.
So I think, the most important thing here, what I want everybody to understand, and what I want everybody to know.
Oh, wait, I do have one thing really quick.
There's one more thing.
Can you give a brief, and maybe it says a brief monoclonal antibody summary I can use on the radio tomorrow? That's Health Call Live wants to know if you can just give a brief summary of what they are.
Okay, so
I don't know personally.
here's a brief summary of what monoclonal antibodies are. And if you want me to participate, just send me a message and I'm happy to call into the radio and tell you this as well. What monoclonal antibodies are antibodies. Remember, antibodies are shaped like a Y. Monoclonal antibodies are antibodies that bind to a specific protein. So in this case, these monoclonal antibodies, shaped like a Y, they get injected into their vein and they're going to bind specifically to the spike protein. When these monoclonal antibodies bind to the spike protein can no longer bind to our cell because that's what the coronavirus uses to bind to our cells. It uses that spike protein. So normally, coronavirus, our cell binds. Now what you have is let me see that. Toss it. Coronavirus, monoclonal antibody to spike protein, can't bind to our cell anymore. It just doesn't fit right. That's the concept of a monoclonal antibody. And so when you understand that, you get a sense of this is just a neutralization. It prevents the virus from binding. If you're infected, you're already infected. The virus is already in the cell. Now you're just preventing further virons from binding to the type 2 pneumocyte in your lung and to your vascular endothelial cells.
I think that's just a question. Dr. Q's asking, and I don't know if this is related to Trump, but it said difference between dilated cardiomyopathy cardiomyopathy and hypertrophic cardiomyopathy? What's the difference?
Great question. So what you're talking about here with cardiomyopathy, all cardiomyopathy means is that the heart, cardio, and the muscle myopathy is diseased. So a dilated cardiomyopathy is you have 4 chambers of your heart, right? Your atrium, your atria, left atrium, right atrium, and then you also have your left ventricle and your right ventricle. A dilated cardiomyopathy is when that left ventricle or even that right ventricle is big. It's dilated. It's very, very big. That's dilated cardiomyopathy, meaning the muscle doesn't work very well because it's dilated. Hypertrophic cardiomyopathy is the muscle is thick as hell. It's really, really thick. So that heart muscle, that left ventricle is really, really thick. It happens a lot in people who may have hypertension, high blood pressure, because that left ventricle is pumping against a very high pressure. And since it's a muscle, when you pump against a very high pressure, just like when you're lifting weights, your muscle has to get thicker and thicker and bigger and bigger. And when it gets bigger and bigger, the muscle can't function as well. The actin and myosin, which is what your muscle is made out of, they don't really congregate too well and they can't squeeze as well. And so you develop a cardiomyopathy.
Okay.
I'm not a cardiologist, but that's my explanation. I'm a pulmonologist, critical care, and internal medicine doc.
I'm not sure if it had anything
There's
to do
one
with
more question from Dr. Q about blood pressure being a risk factor for COVID-19.
The risk factors for COVID-19, what we're discovering, risk factors. So what a risk factor is if you have this pathology in your body, you're more likely to develop severe disease. It doesn't mean you're more likely to get infection. It means you're more likely to develop severe disease from it. Risk factors include high blood pressure. Risk factors include diabetes. Risk factors include obesity. Those are kind of the 3 big risk factors. And we're still arguing over whether or not asthma is a risk factor. I don't think it's a risk factor. I think if you have poorly controlled asthma and you happen to catch the virus, yeah, you're going to be pretty poor. You're going to be pretty sick. But in that case, I wouldn't necessarily say it's a risk factor.
All right. Well, very good. Well, thanks. Let's wrap it up and say goodbye.
We got to say a prayer for President Trump. He's the president. He's a person. He's someone that we want to get better as physicians. We do. We don't want people to die from this illness. It's a devastating illness, as you guys are seeing. 24 hours ago, he was tweeting that he was recovering at home, and now he's in the hospital. You can see how fast this disease can affect your life. Wear your mask. My crew is 8 feet away from me right now. Wear your mask. Wear your eye protection in the hospital. Socially distance. Protect yourself. Understand that the presence of this virus is real. So just protect yourself as much as you can. I'm not going to say shut down the country. I don't believe in that. But I do believe in protecting yourself and doing the necessary things that are going to allow you to remain as healthy as possible. I hope you guys take care of yourselves. If you guys have any questions, comments, feedback, just leave it here. I'm happy to answer those questions. Thanks for being here. Thanks for watching the very first live of Medicine Deconstructed. Remember, I'm arming you guys with information, and next week or on Tuesday, we'll stop back by the Medicine Deconstructed store where you can get some more ammunition. Take care.
Woo!